home with students that were in that class. Is body weight an indicator of health? If yes, why? If no, why? You can hit pause and kind of think about those things. But in class, I talked about, it can be both. I personally think you may get to a point in which weight imposes quality of life issues, and my belief is quality of life is a component of health. And so when quality of life suffers, I think that's a point at which weight becomes too much. No, from a no perspective, no is kind of directed towards the kind of current understandings of obesity and weight, and again, this is where I didn't understand this until I really dug in, and so that's why I'm talking about it. And when you get into your profession, whether it's pharmacy, sports medicine, dietetics, PA, nursing, whatever your health professional field is, you'll get to be an expert in talking to people, working in that area, and understand there may be some times in which you see conflicts that don't match what you think it should be. And so one of those issues is when we look at data. And so here we have the BMI categories, and risk hazard ratios. This is all-cause mortality, and these are participants with type 2 diabetes. But I got to get close and take off my glasses, so pardon me. So all participants here, A, never smoked, smoked. So they have it in several categories. But most people, when they talk and discuss obesity, things like that, it's, overweight is a problem. Well, overweight is it relative to the 18 to 25. So they've got, so one of the things they did here is they broke it down. This 18.5 to 25 is normal weight. What they did was they took the middle category of normal weight and made it the reference point. So we'll get into this when we get into epidemiology, but so that's a reference point of 1. And for those that are in 115, we talked about this in 115. And so the lower end, so it's not even underweight, the lower end of BMI, and this is the case for each, well, except for never smoked, excluding early death. So this is the one where you may see it as being kind of typical and expected. But you have some scenarios in which, you look at smoking, where it's relatively flat. It's high here, so being low or underweight, and this keeps going up, by the way. We'll see it in the next data set. And what I posed to the class was, so if you're a smoker, where would you want to weigh? You'd want to weigh in here or out here. You wouldn't want to be in the low end of normal weight. And so it's one of those things where sometimes it's counterintuitive, because what we hear is increasing weight leads to increased complications. And in this case, in some cases, the increase is not. So obese, for all participants, obese is basically the same as the low end of normal weight as far as risk for all-cause mortality. And so I hope that point gets across, that people say we need to tackle obesity, we need to fight obesity, we need to do this, this, and this, and this to obesity. And it's like, I think we need to tackle the understanding of what obesity is and isn't, and what the effects of obesity are, because it gets really contextual. And that's my issue. Is if obesity was a problem, this goes back to the first question. If obesity was a problem, we wouldn't have to contextualize it and say, oh, well, it's smokers, or it's does this, this, and this. It's obesity should always be a dramatic increase in all-cause mortality, different diseases, etc. But it's not, typically. And so here are some other data. So um, this is from Catherine Flegel. So this is from CDC. So regardless, some of you may have differing opinions of CDC at this point due to COVID stuff, but this is where this came from. And so this is, again, all-cause mortality relative to normal weight in studies that used measured data for participants with a body mass index of 30 to less than 35, so the low end of obesity. And what this is a plot, and so this is less, so it's basically the same graph, just flipped on its side. So this hazard ratio is on the x-axis instead of the y-axis. And so this is 1 and 1. And so what this shows is that these are all individual studies. So this is a meta-analysis. And that those who are at the low end of obesity, some of the studies showed, actually had a reduced risk, significantly reduced risk of all-cause mortality. The obese patients had a significantly reduced risk of all-cause mortality relative to the normal weight, healthy weight participants. Marinate in that, because that's not what we hear typically. If some of you had me in class before, we may have to discuss this, but it's new to most. Now, I'm not saying a BMI of 50 is going to be the same. That's where we got to get into context. What's the degree of obesity? And so it used to be they had morbid, they had obese, morbid obesity. So when you get above 40, and that's kind of where my inklings are. I think it becomes more critical when BMI gets above 40, is when you tend to see cases in which you don't, from my granted, small portion of the population, but when you get obesity at the BMI above 40, you tend to see more cases with more problems, or cases with problems, versus some cases, here, like you don't see this. There may be, as a whole, as a group, it's on the high risk side, so our higher risk side at least. And so over here, so this again touching on smoking. So here we have women, and these happen to be Caucasian women and men. And if you look at the never smoked, this is what you typically expect to see, where obesity is a problem. But in those who smoked, or in this group who has all subjects, so those that include smoking, and so smoking would be even lower here, but it goes up. You don't want to be a lightweight smoker. And same thing for the women, but on the heavy side, it tends to be different. Now for women, it's not much different. I think the risks, especially when you're talking about the majority of the population. So majority of the population is 35 and less. That's when you get to above 35. I would guess you're talking about 10% of the population, maybe 15, versus 85% below. So in essence, it's usually a Nike-shaped curve or swoosh-shaped curve. Some people call it a J-shaped curve, but it's kind of a J on its side. But the level of that kind of varies, and so you have to take it into context. And I think there's some people who are wanting to call for 27 to be where obesity starts, those kinds of things, and it's barely different from 25 being the lowest, or about 24, midpoint between 22 and a half and 30. And so even underweight, and that's the other thing we don't talk about is, the underweight side has increased risks. So I'm sure you've all have heard the term follow the science. So the questions I pose is what does that really mean, follow the science? Because with COVID, that was the term that was always used, follow the science. And then you're supposed to follow their science, whoever was talking. And my issue is we shouldn't have to make that statement. That should just be understood. I get skeptical when people say, well, you need to follow the science. Okay, so what is it? And when we get into this a little bit more, well, just to use this, go back here. Here are all the studies that have looked at mortality and obesity, and you see a range. If you just picked these 3 studies, if you cherry picked these 3 studies, you'd say, oh, yeah, being overweight does increase all-cause mortality. If you pick these 3 studies, or 4 or 5 or 6, you'd say, no, obesity's not. And this is where politics comes in, because politics they're gonna pick R's are gonna pick the data that presents their position in better light. The D's are gonna present their data that presents. They're gonna pick studies and data that represent their preference. And that's, we talked about this too in 115 on the public health side of things, that it's political health and maybe not necessarily public health, because there is politics involved, and so kind of bear that in mind. So the other aspect, so this gets into the homework assignment that's coming up, which will get posted today, Wednesday. When you become a professional healthcare provider, or in the healthcare industry, or even when you graduate and you're posed with either personal issues that affect your family, or your family have, you're gonna have to again, think with your mind and your heart, because sometimes, like, if some of these data, it's not consistent, and so what do you say? It depends. A lot of people don't like that, and so then you have to get into peeling the layers. Do they smoke? Yes, no. Do they do this? Are they African American? Are they Asian? What do we know about those populations? And get down to be more specific than just saying, yeah, obesity is bad. We need to fix it. Because my issue with that is it weight that's really the problem, or is it the behaviors that lead to the weight, or is it the interaction between the environment and genetics that's the problem? Because you could get liposuction, take some weight, 10 kilograms, done, gone, and not really change your metabolic health. So you're lighter, you weigh less, BMI decreases, but you may not be healthier. And so that's my issue with weight loss, just focusing on weight and BMI. I think the behaviors and genetics are important. So you get into a situation in which somebody with differing views than you, or similar, I guess it could be either way, asks you a question that's kind of been politicized. Vaccines. What will you tell them? If you're an expert in your field and there's a controversial topic, what are you going to tell them? Are you going to follow your family decision, your political line, your political affiliation? Because, if you're a Republican and the data seem to support the Democratic view, are you going to say, you know what, the Democrats are right, or vice versa? If you're a Democrat and the data supports the Republicans, are you gonna support the Republicans? That's really hard for some people. But as a scientist, I'm independent, because I don't want to get into this situation of interpersonal conflict. in which, oh geez, I'm a conservative. I need to toe the line with um, whoever the political person who says whatever on Fox News, or I'm a Democrat and CNN saying that this, or this, and um, I can't upset my friends and family who are also Democrats by saying, they're right on this case. That's why I try to be as independent as I humanly possible. And that's the other thing is we'll watch a video the next lecture. I think it's the next lecture in which it gets into this. We can say we're unbiased, but that I think that's humanly impossible to be unbiased. I think we all enter into things with some sort of a bias. So that's also something that needs to be taken into account when discussing these things. So this course is very open. All topics, including assignments, are discussable, changeable, and I want you to know that I understand this course is for you. It's not for me. My goal is to help you. This old dog can't learn new tricks. I'm being facetious. I hope I can. Hey, I did. So for those that were in sports nutrition last semester, and when I was using the presentation thing, I didn't need help to get out of the display settings view that it was set in. So thank you to the students in that last semester who taught me some things, and more than just that. Anyway, so if there's anything you want to discuss, please don't hesitate. This is your time. I'm here for you, and so if there's some things you want to talk about and have questions about, I'm happy to try to help. There may be some topics in which, that's not my area. I can point you in a direction to get some better information, but if, like neurology, I know a little bit about chemotherapy, but my experience is only from the oral side. I don't really know a lot about chemotherapy from an IV port perspective. So anyway, so that's it for today. So thank you, and until next time, have a good rest of your week. And again, sorry, I hopefully will get this situation fixed. Anyway, ciao.